Good morning, everyone. Just wanted to check that the pointer was here as well. So I really want to echo David's thanks then as well, also for me. I really am honoured that WHO was invited and me as the team lead. So contrary to what the program says, I'm actually team lead for health systems and policy for WHO, Malaysia, Brunei and Singapore. And it really just to thank you. I wanted to echo David's views on the importance of the media in many roles that I've played all over the world, including in South Africa. We used to do a lot of media discourse analysis as one of the things that we would do as part of the evaluation of healthcare interventions, health reforms, etc., to actually see what was getting picked up in the media, how was it being represented as part of the evaluation of how successful a reform has been. Also, Varun, who is here from WHO, is our head of communications for our team here in Malaysia as well. And Varun and his team produce for us a summary of the media. We get that globally for WHO, but Varun and Rohini produce that daily, pretty much, for us as a team in WHO in all of the areas that we're working in for Malaysia, Brunei and Singapore. So picking up what the media is bringing out on different topics that are important to us. We also have a team WhatsApp group as WHO, and I can say that one of the things that gets forwarded within that group the most is when we pick up something in the media, and particularly by our WHO representative, Dr. Rabi, when things get picked up in the media, then that we think is important or interesting, we will often forward that within our WhatsApp group to the whole team. So I would really just say I honestly think that this is one of the most important engagements that we can have for all of those reasons, not only because you're important in reporting what's happening, but I truly believe you're crucial to actually shaping change that can be achieved in Malaysia. And so I hope to address both of those things in this presentation. I am Australian by background, tapi sudah lama di Indonesia dan sudah di sini 1 tahun 3 bulan saja. So saya masih belajar bahasa Malaysia, tapi hampir lancar di bahasa Indonesia. Yeah, so a lot of the words are different. So terima kasih. Saya boleh bercakap bahasa Malaysia juga. So I also wanted to just say, but despite that, I am Australian, so I'm also quite informal. And so please, I know that we've got a Q&A session, but if there are any clarifications, I really want this to be more of a discussion, not just a presentation. And then so one final clarification, as I've just mentioned, I am a health economist by background. And so I'm embarrassed to actually say how long for, but over 30 years now as a health economist specifically. And so if there are specific discussions or questions on the health financing issues, I'm happy to address that. And you'll see in some definitions at the end, I do raise that in particular. But I'm head of the team in WHO that deals with primary health care, health information systems and digital health, health workforce, that we're doing a lot of work in medicines and medical product regulation and access, as well as health financing. So just to say that I'll be addressing more broadly health systems. The presentation topic that I was given was around subsystems in the health system. And so I'm hoping that this will just provide a foundation of different ways that a health system can be characterised, and how that might influence the way that reforms and changes are looked at from a variety of perspectives as well. And I really wanted to thank the head of the MMA for raising the issue that communities are part of the health system, because quite often we hear, the health system and communities, but actually communities are part of the health system, and I'll come to that now. So, as I mentioned, I just hope that this was an introductory presentation, and I'm sorry if I sometimes get a frog in my throat, to look at different ways that a health system can be characterised. But first of all, what is a health system? And so these are two definitions, an older one down the bottom, a newer one that WHO regularly uses and get referred to, that a health system is all organisations, people and actions whose primary intent is to promote, restore or maintain health. So that interaction between all of those things, that broad system, how it works, the actions, the people and the structures are all part of the health system. And the second one, the resources, actors and institutions related to financing, regulation and provision of health actions, where those health actions are any set of activities whose primary intent is to improve or maintain health. So just to know what we're talking about when we say a health system. So as I mentioned, there are different ways to characterise health systems. And so when we're thinking about subsystems, I'm thinking more about attributes of those health systems and different ways of categorising them. And one of the most important ways, and we often don't focus on enough, which I'll return to at the end, is what the outcomes are that we're actually trying to achieve. So we get focused a lot on the schemes, the processes, the inputs, but often missing what are we trying to actually tie those to achieve for the population of the country that we're in. And so those common health system outcomes that are most frequently referred to, thank you, I truly appreciate that greatly. The most common outcomes referred to, and obviously the main one is health improvement or maintenance of health. So health status and how that changes. And so we often look at healthy life years gained, for example, as one key measure of that, not just the extension of life, but how well those additional years of life are lived in terms of the quality. And not just the level of that, but who benefits. So how equitable are those health gains distributed across a population? Really important to be questioning that whenever we're looking at health reforms taking place and reporting on them. Will this actually lead to the health changes that we want, and who for? And then financial and social risk protection. So a health system also, if I'm accessing health services or getting health promotion messages, my access should not put me at risk of financial hardship. And I'll go further into the definitions of that at the end. But basically, financial hardship means any spending that I make that negatively impacts my welfare. And so we want people to not have to be falling into poverty or risk falling into poverty or further into poverty to get the health improvements that they have a right to achieve. And social risk protection means that they should also feel safe and heard, that my personal safety, my experience of my culture, everything else is not at risk because I am accessing health services. So I have a right to be treated with respect, for my perspective and preferences to be valued, etc. And that's the social risk. The do no harm principle goes beyond the do no harm just with the clinical outcomes, but also in the way that that person receives, perceives their whole treatment of the whole person. Then resilience is another one, and particularly in the wake of COVID, but also as we know that we're having more and more health crises, health emergencies more frequently, and more severe. And that will only continue with environmental change, with the urbanisation, more interaction between animals and humans. And so health system resilience is a big focus that has grown in terms of the outcomes of a health system. And that's the ability of a health system to not only prepare for and respond to and mitigate those health emergencies, but at the same time, and recover from, how quickly it recovers from those health emergencies. But during that response, can that health system also deliver the essential health services that people need? And so that's an outcome of the health system as well. And then finally, and these are, if you like, the high-level outcomes, responsiveness is how well I actually meet the non-health expectations of the people that I serve, of the population, and also how adaptable to change and future needs, and how quickly the health system can do that. So you can see there are 5 different dimensions, and they're the high-level ones, if you like. And then as part of that, intermediate ones are how efficiently are we doing that? So how, for the given resources that we're using, human resource, time, money, etc., how much health gain do we produce? That's actually the true definition of efficiency. Are we using the combination of inputs, allocating across providers, resources in a way that we are maximising the health status for the population for a given dollar that we spend, and that, or ringgit that we spend? And that's how efficiently the health system is performing. How equitable is it, both horizontally and vertically? So some of you might have heard this, and quite often I hear people talking about, well, but that's not equitable because everyone's not paying the same, or something like this. But everyone paying the same is not equitable when we have people that are poorer. So I should have put here, you've probably all seen the diagram with the different steps, the level of the steps, and someone not being able to see over because they have a different starting point. And that's the concept of vertical equity, which is crucial in health, which says that for greater need, someone should have greater access to health services to address that greater need. So where there's a backlog, trying to change those equity gaps. Horizontal equity does mean for equal need, people should be treated equally, regardless of ability to pay, race, etc. So that's horizontal equity, and you'll often see those two together. And then quality, clinical quality, hotel quality, technical quality, all of those things. Coverage is then meaning the people who actually take up services. So how well are we covering those who need certain services? What proportion of them are receiving them? And in universal health coverage, that's one of the dimensions. And then finally, access, because access does not necessarily mean that I'm going to take up those services, but we can look at access. So there's, if you like, a cascading upwards level of outcome in the health system there. So I was also very, very pleased that the head of the MMA brought up this integrated people-centred health services, or health system that is integrated and people-centred. And that you see that a lot in RMK 13 referred to, and in the National Health Plan and strategies referred to as well. So this is a core goal of the government of Malaysia, is to increase the integrated people-centredness of the health systems and services in Malaysia. And when you look at that, that's a WHO framework called the Integrated People-Centred Health Services Framework that I think was released in around 2017. And these are, if you like, different categories or subsystems within that framework. So there are 5 that can be usefully looked at to see how well a health system is performing in terms of both its capacity to and its performance in delivering integrated people-centred health systems. So the first pillar of that is to engage communities. And that's everything from actually ensuring that community preferences are included and that service changes are co-designed with communities. That also we're supporting people, families, households, communities and empowering them to participate in their own health. So how are we doing that as part of the health system, not just about treating them when they come to us, but empowering them to live healthier lifestyles through the environments that we're creating in the community, all sorts of things. They're addressing the social determinants, the broader social determinants of health. And very importantly, in countries like Malaysia, where we're facing an ageing population, increasing multiple chronic diseases, actually supporting the informal caregivers that are so important in most countries in this region. So many, and even through different groups outside work I belong to, that there are so many children, younger people, husbands, wives, sisters, brothers supporting the care of people in their households. How do we support them to provide the best health improvements? So all of those things are really important in engaging communities, and also engaging communities in the monitoring of health service performance and giving them information that allows them to do that. And strengthening a governance and accountability, including looking at patient-reported outcomes, but mutual accountability. And so I think you also brought up data and how important data is. And I often say that about even having data sharing agreements, for example, across public and private sector is very important for this mutual accountability, and that's across providers, communities, etc. as well. And also you see increasingly, and David might refer to this later in developments in the UK, for example, you increasingly see local councils now being involved on the ground with the health system, together with the health providers or health structures themselves, so that there can be accountability across the range of things that actually impact health, and that can be really important. Then reorienting the model of care, extremely crucial in terms of prioritising primary health care and community care. And I'm sure people get tired of hearing this from WHO people. But the reason that we do this, that we emphasise this, is because, and you've probably heard these statistics, but it's been shown that around 90% of the health interventions most essential to universal health coverage and achieving it can be delivered through a primary health care approach. And about 75% of the total health-related SDG benefits will be achieved through a primary healthcare approach, can be achieved. So if you think about the relative cost of delivering through a primary healthcare approach, then having those huge benefits, the investment in primary healthcare, the government financing to health, and the proportion of that that's invested in primary healthcare, we know has a direct relationship with universal health coverage progress in a way that private financing does and private provision does not, for example. So that primary healthcare is really, really, really important. And also that focus on prevention, promotion, and I'll talk about the essential public health functions and leveraging digital health. Coordinating services is the fourth pillar of the integrated people-centred health services and systems framework. And this is across providers as well as across programs and with the individual in mind. And this is very crucial. I'm sure that many of you, more so than myself, but I'm supporting 3 elderly people at the moment navigating the health system in Malaysia. And one of the things that I've noticed is, for example, someone who's very frail and in end-stage renal disease has to go back to the hospital. This clinic is on at a different time from this clinic, and then to get the medicines to come back this different time. He's had a fall, to get the physiotherapy, it has to be a different time. So he could be going back and forth to the hospital 4 times within a period of 2 weeks. And so that's a very simple example of where perhaps that information sharing, that patient transition, that information sharing between departments, etc., practically to deliver coordinated care is something that is actually crucial, but we don't look at enough in terms of health system performance. And yet from a patient perspective, that's probably one of the things that's going to affect me and my experience of the health system the most. So particularly that patient experience in transitions as well is particularly important here. And the donor community, of which I was part of and worked in HIV for 12 years, we are also to blame for the verticalisation of a lot of diseases. So now we're even doing it, even though many people with NCDs have multiple chronic diseases, we're still doing it now with diabetes funding, hypertension, TB, all of these things that's very vertical rather than treating the person as the whole person and delivering together, which is what this coordination is about. And then finally, the enabling environment is really around those traditional supportive, if you like, inputs like the WHO building blocks, but how they're provided in a way that actually supports the integration of services and systems. So some specific examples where this becomes particularly important, and WHO has recent frameworks on each of these things. One is about integrated care for older people, and that's a variety of things. Malaysia has actually been one of the forerunners and has a number of what we call age-friendly cities in Malaysia, where WHO works with the mayors often and looks at everything from the transport to access to services, to healthy environments, to green spaces, all of these sorts of things that a city might want to do to become age-friendly so people can get around, live their full life more actively. And that's where maintaining intrinsic capacity comes in. So my ability, my sensory abilities, my mobility, my nutrition, my cognition, all of those things, maintaining my intrinsic capacity becomes so important as we age. And yet it's an outcome that we often don't look at in terms of health system performance. Long-term care and again, caregiver support as part of that. And then the integrated care for older persons package actually looks at integrated assessment and the individualised development of a care plan. And both the NHS and in Australia, we actually have financing for the development and review of this care plan that is given for an individual older person, for example, and also social prescribing outside of the health sector. So integrated chronic disease management, obviously another one as well. And then how we finance in a way that actually supports prevention and early detection. It won't be a surprise to any of us that most of the financing goes to curative. And in Malaysia, that early detection, I was shocked to hear from the Breast Cancer Society, for example, that they mentioned so I don't have this down on paper, but they mentioned that about 60% of the cancer cases are found in stage 4 in Malaysia, and the average globally is around 30%. So that late detection here is so crucial, both for the outcomes but also for the costs, but mostly the outcomes for the patient. And so how do we actually work to ensure that we're delivering services in a way that promotes and supports that early detection more effectively? And then part of that is taking a life course approach where we actually say, and any of us that have worked and lived overseas, and me even as an Australian going to do my master's in the UK, I was amazed that I got to the UK, and within 3 months I had a reminder from the NHS, you haven't had a pap smear in this many, and I was like, wow, big brother, big brother, what happened? And my primary care providers in Australia will constantly follow me up. You've now turned 50. You should have had these screenings. You haven't had this screening yet. Constant follow-up. So those kind of, you're an adolescent, we really want to reach out to you with adolescent mental health services. All of those kind of things that are based on your life course stage, how can we get proactive about that and integrate services by life course stage is really important. And then another way to look at the subsystems that can be more useful than the inputs that we'll come to is the functions. And so the functions of health systems to deliver curative services, for example, but then also to deliver preventative services, to surveil for disease risks, outbreak risks, etc. They're all functions of the health system, if you like. So you can imagine there needs to be financing, there needs to be workforce, etc. to do that, but they're functions that the health system should perform. And again, a country like Malaysia and many of our countries in this region, most of our countries in this region that have an ageing population, growth in NCDs, etc., one of the most important things is the capacity of that health system and the performance in delivering what we call essential public health functions. And this is particularly important as any discussion of insurance, public-private partnerships, etc. come in, because it's the essential public health functions, and anyone with any economics background, you'll always hear about what do public good means, and that private markets will never allocate enough resources to things that are public goods, and they're things that provide broad population health benefits and will be underinvested in unless there's routine operational intervention. And so these are the list of essential public health functions that a number of countries for some time got together and discussed. And just recently, there's actually a framework on governance for the essential public health functions that WHO has put out with this unified list of essential public health functions. So you as journalists, when you're looking at how well are we really doing this prevention, promotion, all of these risks of non-communicable disease, health outbreaks, these things are actually crucial things that the government of any country, more so than a private sector ever will, need to be looking at delivering, and that good financing to maintain it. So it's always one of the first things I look at in the Malaysia National Health Accounts or any national health accounts is how much is going to these functions in the expenditure system in the domestic government resourcing. Then obviously another characterisation can be the actors within the health system. And for you as journalists, I would say this is one of the most creative ways to get a series of articles on a particular health reform or health change that's going on, and then do a series from different perspectives. And Kenya has been doing this with a huge amount of success. Their health section in their main newspaper has become one of the most read and engaged with sections by having these series that they've done looking at different changes from different perspectives. So these are just some in a health system. You'll have the individual themselves, but then my family as well, both nuclear and extended family. How does any change affect families? How does it affect the individual? How does it affect communities, and how do they engage with that change? Employers, someone mentioned that we've been having meetings recently on some health financing potential options, and we've had the heads of all of the different Malaysia Employer Federation, Business Council, etc. as part of that, because that employment and still wanting to incentivise economic growth and not constrain employment, etc., is also really important. But also the notion of health as an investment in productivity, in many productive activities at home and at work. So there's many different perspectives that we can use there. Local government, as well as a really important one, where we need to be looking at health beyond just the health sector itself. Education, transport, housing, and particularly the social sector is really crucial for the challenges that Malaysia faces. So having a look at one single problem or change or reform, but taking different perspectives on that, how it affects different groups in different ways, is maybe something that we could be thinking about in the media as well. And then finally, the last one I'm going to come to is, obviously this is the traditional one that most often people fall back on, and yet we as WHO now don't refer to this as much. Interestingly, we've kind of moved to the integrated people-centred systems, essential public health functions, but this is more an input base, and that's why it's called building blocks. This is about what health workforce, what human resources for health do you put into the system, in what sort of mix, how are they paid, etc., then crosses your financing and your health workforce. So one of the downsides, this has been a really, really important, and it still is, a really important way to look at the health system in terms of those crucial inputs. But one of the downsides is quite often it made silos between these different inputs. But for example, how providers behave, and I'm sure the head of the MMA will back me up on this, the way that how providers behave often relates to how they're paid and how they're financed. I used to work in eye care, and cataract surgery is one of the two things, cataract and caesarean section, are the two things that we as health economists often look at as the most quickly changing frequency of procedures, etc., done based on the way that providers are paid. So there's a lot of crossover here. So always, too often looking at just these in a vertical silo is not always the best way to look at health system performance. So finally then, one thing that I would mention, and I've referred to the paper here because it's a really great paper if you're interested at all, is to really get more of an objective and outcome focus on the development, the monitoring, the implementation, the monitoring, and I want to add to that the reporting of health system reforms. So it's making sure that we link the means with the end. And what we've found in a number of dialogues, and it's not unique to Malaysia, it's everywhere, is that people want to get down to the nitty-gritty of, do we have a social health insurance or not? Do we do performance-based financing or not? And they're important questions, but more important is, well, what are you trying to achieve by doing that? What problem are you addressing? But more importantly, where do you want to get to in the future? And is that bridging a gap between the health system that Malaysia wants to see in the future, where we are now? How does that thing actually relate to bridging that gap between where we are now and where we want to go in the future? So objective-oriented health system reforms really look at trying to bridge that gap and articulate that clearly. They're often therefore informed by evidence about what works best to do that, both locally and globally, and they're continuously evaluated and then adapted based on, is it actually achieving what we set out to achieve through doing that? So just finally, and I know that I'm 2 minutes over already, so I just wanted to raise a few things, specific things, where I think that health system journalism has an opportunity to really shift some important dialogues and contribute to strategic communication. And one is that health is an investment. rather than just a cost. And actually, I think Malaysia probably does this better than many countries I have worked in, where in strategy documents, health is always there on the cost side. But then they talk about, human capital investment. It's always education, training, etc. And I'm the one going, human capital, the other half of the human capital index is actually the health status. So increasing your human capital is directly related to the health improvements that you can also achieve. So the productivity gains related to health gains, etc. as well. How do we actually talk about health as an investment more in the reporting that we do? The primary healthcare orientation, I had to put that in here because things like, for example, gatekeeping in Malaysia, or what we talk about having primary healthcare as your first contact care, is often talked about and debated in terms of, but people need freedom of choice versus this gatekeeping system. And actually, I don't know the exact percentage, and I know that this is being broadcast, so I don't want to say exact percentages, but most countries have a system where you either get heavily penalised or you cannot see a specialist without going to a primary healthcare provider first. So it is not unusual, it is actually the common situation. But then you need to look at the social preferences and all the benefits and costs of that. But that's one thing that I think that we could be engaging in more, that benefits of the primary healthcare. And it's great that in the RMK 13 we've got that shift in proportionate resourcing to primary healthcare. But again, that's an input, which is easy to measure. Is it achieving the things that we actually want it to achieve if we're getting that resource change? And how are we getting that resource change? Another one is broadening the health workforce perspective. So I'm working with the ministry, as some of you know, and that's also why I love UKM. UKM has one of the largest number of allied health professional training programs, and number of allied health professionals trained here. And allied health professionals now in high-income countries globally, in the UK and Australia, are the fastest growing group of health professionals because of ageing populations, NCDs, etc., and high in demand for services. And yet in Malaysia, they've been growing at about 1/8 of the rate that they've been growing in Australia and the UK, for example, and there hasn't been one question in Parliament about allied health professionals for the last 3 years, versus the number of questions and discussion and debate about doctors. And doctors are important, but actually we know that the best care is delivered through these interprofessional teams. So how do we, and I would really love to now engage some of the media in, and we're going to be, Varun's going to be in this discussion about the importance of the allied health sector, as well as the 10-year blueprint will be released later. And then benefits of early detection, where we've just talked about bringing out individual champions and stories of that, I think could actually shift behaviour, and you could have a direct impact as media on health gains in Malaysia. I won't go into the definitions, I'm happy to do that, but I just put some definitions up there of things that are debated and talked about a lot at the moment, and particularly in my area of health financing, where having the definitions is very, very important. And so things like strategic purchasing, for example, where it's often discussed that is done through a health insurance system. Strategic purchasing can be done, it's just about how providers are paid and whether that is done in a way that helps and supports different health systems' goals. So purchasing is about the way that finances are allocated to providers to deliver services. It's not about, the procurement is different from purchasing, if you like. And you can do that in a government tax-funded system, you can do it in a health insurance system. Having good strategic purchasing is not dependent on the arrangements that you have for the structure of the health financing system. So just some definitions there of universal coverage, what social health insurance versus national health insurance is, etc. Thanks very much.
Thank you very much, Debbie. Don't go back to your seat quite yet. We have some time for Q&A now. Debbie has covered quite a large kind of landscape of issues and terms related to health systems. And I'm sure that there are many of you in the audience who will have some questions, particularly of clarity around some of the terminology that is used. So please do not be shy. Please ask any question that you feel you would like to ask in order to get a full and proper understanding of what's been covered so far. Anyone? Yes, please.
Hello, good morning. My name is Melissa Idris from Astra Awani News. Debbie, could I get you to go back to the slide on shifting dialogues, please?
Perhaps. I don't know how to go backwards on this
Oh,
one.
dear.
Oh, okay, there we go. Yep.
Okay, so I have two questions about this slide.
And that's just some examples. Yeah, they're going to be many.
Oh, fantastic. Okay, so the first one is on primary healthcare orientation. You said something about measuring output is harder than measuring the increase in input. Could you elaborate what you meant by that?
Yeah, so truthfully, that is normally harder. So, for example, the RMK13, and it's a good thing, but the RMK13 has as one of the indicators over the next 5 years to shift the proportion of total health expenditure spent in primary healthcare from 27 to 32%. So up 5 percentage points, for example. So that's relatively easy to measure. Malaysia has a very good national health accounts reporting, etc., and they've got a definition and measurement of primary healthcare for Malaysia within that. But then I would say, so getting that greater expenditure in primary healthcare is good, but how is that being achieved? And what is that producing in terms of that primary healthcare approach? Is it on prevention, promotion? Are we seeing more people detected earlier for diseases? Those kind of things need a way of thinking to say, what are our major challenges in Malaysia that primary healthcare can best address? And I would say early detection might be one of those, for example. And is this increased investment in primary healthcare actually achieving those things? But also just articulating as the media, I think understandably, and Malaysia is not unique in this, it's very understandable that high technology hospitals, etc., politically in every country, not just Malaysia, in every country, can be highlighted more usefully. And, making sure that we have good public primary health care, that people have access continuous to their GP, how that's performing, how that's affecting health status is far less sexy, if I can use that terminology. And so I think if I can say one thing, I think as the media getting together to say, how do we as a media, perhaps together with the Citizens Health Initiative, etc., develop stories, focus in this area that actually brings more attention to it as well.
Thank you for that. One more question about broadening health workforce perspectives. I love that you brought in allied healthcare workers. Can you elaborate how we can have more of those stories, those voices?
Yeah, no, thanks for that. And I'm absolutely serious, and Varun knows this, where we will be as the WHO office reaching out to the media a little bit more on this, because we have had a collaboration with the Ministry of Health on allied health since 2019 and even before that. So the profile of allied health professionals, and then development framework, and now the development of a 10-year blueprint where we've had large stakeholder consultations, online surveys, focus groups, etc., to better develop the allied health workforce. Not just talking about numbers, but how do we use them more effectively? How do all of those sorts of things? So definitely, I think, I'm trying not to be too controversial here. What do I say? So let's just say be controversial, maybe at the tea break. For example, where allied health services are not funded in key benefit packages. So, for example, the Ministry of Health, as we all know, has now declared obesity as a disease, which is great. That means now that dietitians, so whereas nutritionists before could treat, now dietitians will need to treat. And what does that mean for dietitian services? So in a lot of private health insurances and social health insurances in a lot of countries, to be honest, I get asked to, in my private health insurance in Australia, here are 3 free, because I'm big, let's be honest, here are 3 free exercise physiologist visits for you. We really encourage you to take them up. Here's 3 free dietitians appointments. We encourage you to take them up, because they know that ultimately that saves them money. So things like that, are we financing the things that will actually make a difference in benefit packages? If you see that sometimes these things aren't being promoted, does an audiologist who has the expertise in hearing aids, etc., can they deliver those things without going through many loops of approvals? All of those kind of, so areas like that, and how our allied health professionals, at the moment in Malaysia, there is a huge concentration of allied health professionals in hospital level and not down in primary care and community services, and in most countries that's the reverse. So how also do we look at getting these community-based services for ageing populations, that prevention, promotion, but for example, an allied health worker working in primary healthcare at the moment in Malaysia does not have the same promotion possibilities, because you have a higher level of post available in a hospital. So it's like we're linking specialisation at a hospital with your level of promotion. So how do we actually incentivise, how do we change that to recognise that primary community care as an important aspect of allied health services where they have those future career progression possibilities? So all of those things, there's some specific examples. So you're smiling, so I hope that they answer the question. But we would definitely, we look forward, I know the Ministry and WHO look forward to working with the media more in that area, for example.
Thank you, Debbie. I'm also Debbie, although I use Deborah, my full name. I'm a freelance writer. I have a particular interest in palliative care, and I noticed one of your slides which described palliative care for later stages. But it's my understanding and observation that it is not necessarily for later stages now. I think there is more push by hospices and just articles in the media that palliative care can be introduced alongside regular treatment, and that hospice is more for later stages. And there is also research and statistics, which I'm sorry I can't recall offhand, that shows the palliative approach introduced alongside treatment can result in better outcomes for some patients. This is a particular interest of mine, partly because of experiencing it with both my late parents who went through palliative care, not in just because they were already at the later stage, and it did give them better quality of life. So I don't know, I just wanted to point that out, that maybe there's a shift in perspective now on palliative and hospice care, and that it's good to probably have more conversations and understanding about it. I think introducing palliative care early on, especially for geriatric patients, can improve quality of life and perhaps reduce suffering a lot more, not just for the patient, but for family members as well. So that's my comment. Related to that, a question, would you have seen anywhere, any model in other countries where palliative care is covered by insurance?
Two good points. So I just want to point out my later stages one was with regard to chronic disease management, not necessarily for the elderly only in that case. And so I do think it depends on what definition of palliative care you're using. So, but for example, ongoing treatment and supporting compliance for treatment for different chronic care conditions would not necessarily be a palliative approach at that stage, but for certain aspects of people that are in later stages of disease, definitely starting earlier, but they are in later stages of disease, palliative care is really, really important. In terms of the elderly, I think there are so much things, and this is where the life course approach, recognising that healthy ageing, and I'm speaking to myself here as well, every time I exercise at the moment and try and lose weight, I go, okay, if I don't do it now, I'm going to be facing the consequences of that, I know, in 10 years' time. And that's similarly right back from when we're teenagers, children, etc., all the way through the life course. So definitely, I think there for healthy ageing, there are so many things that need to be taken into account. In terms of your answer about the insurance, it's a very, very good question. And the answer is yes in some countries, but quite often there is a specific insurance or a specific package for it within an insurance system. Because and this is one thing that we were talking about before. So insurance works best. If you think about all other aspects of insurance, it's for those large, unpredictable events. So you talk about insurable risks versus what general health systems should provide. So insurable risks traditionally, and health is the one area where now we've departed from this a lot, and it's often why insurance systems become less efficient, is that we've now shifted the focus away from those big insurable risks. So the long-term sort of care, palliative care, care for older people, disability, etc., many things that most of us will face, insurance isn't always the most effective way to finance those things. If it is, there's usually a specific mechanism set up because they're ongoing, recurring costs. So you've probably heard, for example, it's not exactly the same thing, but the NDIS, Japan, for example, has a specific long-term care insurance system. In Australia, we have the National Disability Insurance Scheme. The cost of that has been astronomical, and then looking at how that gets managed because of these ongoing costs. So there are huge issues to deal with that through an insurance system, we can talk more about that from a health financing perspective if you like. But insurance systems work best when they are looking at less predictable costs. Yeah.
Thanks, Debbie. We probably got time for one more question.
Oh, sorry. Thank you. Good morning, Debbie. My name is Manveer. I'm a WHO patient advocate, and I represent Vital Signs Asia. So we're talking about financing, and you just mentioned that we don't do enough in preventative care here in Malaysia. There's not enough screening for breast cancer, that kind of thing, right? Should we be considering health insurance, a social health insurance in Malaysia, so that we have enough financing down the road to do a lot more in preventative and screening, which you've just alluded to the fact that it does save money in the long term. Obviously, it saves our money. And obviously, the government becomes a bit more efficient because there are pockets or buckets where there's more money distributed for this kind of financing. But somebody needs to pay for it. So should we in Malaysia be considering it? Because that is something that is a political minefield, obviously, in Malaysia. But should we be considering it over the long term in order to make sure that our citizens are better covered?
So this is going to, there's work going on at the moment that looks at different alternative health financing pathways from an evidence-based point of view. So I'm just going to speak now on what the global evidence is, and just going back to my point before. So screening, prevention, and those kind of things that we would say are the essential public health functions are generally less efficiently delivered under an insurance system than they are through a public financing type system, because they provide the population health benefit, but then making sure that that's invested in. So if that's not invested in, then why is it not invested in, and how you can get greater investment in that, and whether an insurance is needed or not. But for example, in a lot of insurance systems, that regular checkup or screening actually is not included, even when you have an insurance system, because of that predictable one-off risk, etc., and because of the efficiency, the incentives for insurers to deliver that. Yes, there would be the cost savings, but the incentives in terms of often the for-profit provision and that kind of thing often isn't there as much. So what I would say is I don't think universally most of the time an insurance system is not the answer to that, but it can be an option if other means of financing it that actually would be more efficient are not happening. What I would say in Malaysia is that I don't know that it's all just about the services not being there or provision. From what I understand, even for groups that service has been there, and for a lot of people that were diagnosed as having suspicious results and needed follow-up, that in a particular area, only about 50% of the people that had been given reminders of having a suspicious result were coming back to actually get that further checked. So finding out why that is it a thing about I'd rather not know? Is it about transport, distance, availability of services, trust, those kind of things? That's where I think getting to the bottom of not only investment on the provision side, but also the take-up of those services is crucial.
Sorry,
Thanks,
can I
Debbie.
quickly ask one
Okay, one more.
simple question?
Okay.
Morning. Thanks, Debbie. This is Raymond. I'm from the private digital house side. Quick question. In your opinion, what you've been doing, what will be the ideal or optimal or expiring health system and care pathway for Malaysia and South Asia, judging the fact and considering that, in terms of the differences in literacy, health literacy, infrastructure readiness, and policy and so on. What is the ideal and expiring, or what we call the utopia health system, in your opinion, that suits Malaysia and South Asia?
There isn't one.
Mm-hmm.
There isn't a single one at all. So it depends on your starting point, who you're talking about, what the goals of your health system are. As I was saying, those objectives. There is not one single utopia, even if you're talking about a group of countries with similar characteristics. You'll find that different structures to the health system work better, even though you would say that they have the same level of income, the same public, private, etc. mix. So the truth is there is not a utopian answer to that.
But I would like to say that by the end of today, we will be able to put that question to you. And you can tell us what should be the ideal system for Malaysia, hopefully. Thank you, Debbie. I think we've come to the end of that first session. What we have next is a break with a group photo. There's just one thing I wanted to maybe quickly add. When I shifted from being a clinical doctor to moving into public health, and I was studying public health, one of my light bulb moments was when I saw data showing how different countries have different performance levels in terms of health. There were some rich countries that had very sick populations, and there were some poor countries that had very healthy populations. So why was this? Why are some countries good at generating good health, and some countries are bad at producing good health for their populations. One of the key differences, of course, is around prevention. That those countries that deliver good health at low cost are those countries that prioritize prevention. And comes back to the point that Debbie was saying about hospitals being glamorous, saving lives is glamorous, but primary health care is less glamorous and preventing disease is less glamorous. And this is something for journalists and media organizations to try and make primary health care and disease prevention more glamorous than it is, or as Debbie says, more sexy than it is. But it's very striking to see how different countries perform differently. And perhaps one of the things that we should try and do is to show how does Malaysia compare with other countries in the region or with other countries in different parts of the world. Yeah. But let me stop there and hand over to Fun Fong, who will give us instructions about the next session. Is there a group photo?